Hello everyone, my name is Eddie Kov and I am a second-year internal medicine resident at Verde Valley Medical Center sponsored by Midwestern University. Today I will be presenting a case on alcohol-based hand sanitizer ingestion complicated by functional blindness and symmetrical bilateral frontal lobe and basal ganglia infarcts. To start off with an introduction, alcohol use disorder and alcohol dependence is not only prevalent in the United States but is an ongoing issue worldwide, with alcohol-related mortality accounting for approximately 3 million deaths, or about 5.3% of all deaths globally per year. Recently, with the COVID-19 pandemic, the CDC recognizes hand hygiene as an important preventive measure to control the spread of SARS-CoV-2 with the use of hand sanitizer, and recommendation that the hand sanitizer contains at least 60% ethyl alcohol or 70% isopropyl alcohol. During the pandemic, there has been a shortage of hand sanitizer in the United States due to the increased demand, leading to increased importation of the hand sanitizer, which have been found to contain methanol. We have seen rising numbers of methanol exposure and ingestion since the course of the pandemic, especially in the states of New Mexico and Arizona. Methanol is a known toxic agent, and exposure through inhalation in skin or ingestion of even small amounts can be life-threatening and can cause permanent neurological deficit due to its toxic metabolites. Thus, early recognition and treatment is crucial in terms of prognosis. This case starts with a 47-year-old Caucasian female with history of alcohol use disorder, bipolar, anxiety, and major depressive disorder with suicidal ideation, who presented to the emergency room with complaints of sudden onset of decrease in vision, shortness of breath that had been occurring for the last 2 days after ingestion of hand sanitizer. Patient was unable to recall the brand or ingredient of the hand sanitizer she ingested. Vital signs showed afebrile temperature. Patient was tachypnic and tachycardic with heart rate 98, oxygen saturation 98% on ambient air, and blood pressure 135/63. Physical examination showed a thin female who was awake and alert, fully oriented with fluent speech, and no odor of alcohol on her breath. Eye exam showed full ocular movement, central vision field loss, pupils that were non-reactive to light without significant direct or consensual pupillary reaction, optic disc flat without edema or hemorrhage, and no conjunctival injection, protosis, or chemosis. Significant labs included bicarbonate of 5, anion gap of 29, serum osmolality of 313, and a calculated osmolar gap of 36.4. A venous blood gas showed pH 7.02 and a partial pressure of carbon dioxide of 19. Serum ethanol levels were not detected, and additional testing for volatile alcohol, including methanols, were not available in the hospital and needed to be sent out to an outside facility. Of note, initial methanol levels did return after patient was transferred out of our facility, elevated at 57 milligrams per deciliter. MRI of the patient's brain, orbit, and face, with and without contrast, were obtained and demonstrated punctic foci of restricted diffusion within the basal ganglia, which is compatible with methanol ingestion. Provided here are snapshots of the MRI with the lesions highlighted by the red arrows. With the combination of visual changes, a history of unknown alcohol ingestion, a large osmolar gap, and the MRI finding, this did raise high suspicion of methanol poisoning. A stat consultation for nephrology was placed for emergent dialysis, and poison control was contacted and recommended starting fomepizole per protocol of methanol toxicity. However, despite dialysis and significant improvement of patient's lab, patient only showed minimal improvement of her vision. This case was rediscussed with poison control, who recommended transfer to a facility where methanol levels could be obtained daily in order to guide management. Reviewing records from the facility that the patient had been transferred to, repeat methanol was less than 10 and fomepizole was discontinued. Patient was evaluated by ophthalmology and was started on a 3-day course of IV solumedrol with no other treatment indicated. After patient had been stabilized, she was then transferred home. For discussion, methanol, a known toxic alcohol, is industrially produced and seen in the use of solvent, pesticide, and alternative fuel source. Once it enters the body, methanol travels to the liver where it gets metabolized to formaldehyde and then further to its toxic metabolites, formate and formic acid. The accumulation of these toxic metabolites leads to the development of severe metabolic acidosis and serious irreversible neurological sequelae, including seizures, comas, and possibly death. Though the exact mechanism is still unclear, formic acid is a known inhibitor of mitochondrial cytochrome oxidase, which causes hypoxia and acidosis and targets high-energy demanding organs such as the optic nerve, the retina, and brain structures. Neuroimaging studies are typically not obtained to make the diagnosis of methanol toxicity. However, it can provide evidence suggestive of methanol toxicity, especially in areas or hospital where methanol testing may not be available. The most common MRI finding is seeing bilateral putaminal necrosis with or without hemorrhage, and less common findings include cerebral and intraventricular hemorrhage, cerebellar necrosis, diffuse cerebral edema, bilateral subcortical white matter necrosis or edema, and optic nerve necrosis. Though these findings are not specific to methanol toxicity, given clinical findings and history, this can help to distinguish other alcohol-induced neurological disease processes. Treatment of methanol poisoning includes fomepizole, which is an alcohol dehydrogenase inhibitor that prevents the metabolism of methanol, and consideration for consult to nephrology for emergent dialysis if patient presents with severe metabolic acidosis and an gap greater than 24 and any sign of end organ damage. In conclusion, in order to continue proper hand hygiene to prevent the spread of COVID-19, there has been an increased demand for alcohol-based hand sanitizer, leading to importation of non-FDA approved hand sanitizer containing methanol. This has caused recent increase in methanol toxicity cases, and prompt recognition of methanol intoxication, including high anion gap metabolic acidosis with visual deficit, for early treatment becomes crucial in terms of prognosis. This case emphasizes the importance of timely diagnosis, using different modalities for diagnosing and treatment of methanol toxicity, especially in rural areas where there may be a lack of access to timely laboratory measurement of methanol levels. Here's a slide listing all my references throughout the presentation, and thank you again for your time.